this is, I think, a pretty good segue to our next topic. So post-protocol therapy on EV-302 would be interesting, of course, to see that data come out and see what actually patients got, after progression on the EV-302 regimen. But where we stand currently with EV-Pembro perhaps adopted for many patients and most patients, where in parts of the world at least where it's available, upon progression on EV-Pembrolizumab, because unfortunately that will happen for many patients, what would be your therapies of choice?
So I think that the community standard in this setting would be gemcitabine platinum or your favorite platinum-based combination. I think that in patients with FGFR3 mutations, erdafitinib of course comes to mind, and personally I would probably use erdafitinib before gemcitabine platinum in that subgroup of patients. But I think the community standard is gemcitabine platinum. Sacituzumab govitecan is out there, but it's now approved only post-platinum and checkpoint. So it remains to be seen that if that would be allowed in the post-EV-Pembro situation in the clinic.
Mm-hmm. It's interesting that sacituzumab is approved in triple-negative breast cancer. It's actually pretty commonly used. And I think some providers may have more experience using it in breast cancer. In bladder cancer, it's active. It's not as active as EV was as monotherapy. It was about a 23% response rate as monotherapy. And actually, you, Dr. Grivas, just published a study looking at it in combination with immune therapy. Mm-hmm. Maybe you can tell us about that in just a sec. But with a 23% response rate in that Trophy U01 trial, it's active. But I agree with you. I'm not sure I'd jump to sacituzumab. We don't really know what the activity of platinum is in the second line post EVP space. And recall that they're going to be progressing despite immune therapy, so they're going to have more aggressive disease, those patients. But I do think you're right that platinum should probably be given. We obviously need better data sets, and hopefully they'll be coming out soon.
Totally agree. And Karine and me were discussing at the Euromigos meeting if you had actually an idea about the trial in that space. Mm-hmm. Can you tell us a little bit more about your thoughts on that?
Yes. So we were thinking about exactly this question. How is chemo going to perform in the second line setting post EV-Pembro? But also, I think one of the concerns that we all share is with the neuropathy that might linger from EV-Pembro, how many patients will actually qualify for cisplatin? And so would we expect still that 40-ish% range of response rate in the second line setting of chemo post EV-Pembro? As we talked about, sacituzumab is generally more in the 20% range. There are no trials comparing the two in that setting. There may be ongoing trials looking at, I know Trophy added some cohorts in the post EV-Pembro looking at sacituzumab with or without immunotherapy. And that also begs the question of repeating immunotherapy. We have seen in kidney cancer that hasn't read out, but will the same be the case in bladder cancer?
And that's a great question. Actually, going back to your point, Terry, and Karine, we did publish just a couple of days ago, platinum refractory patients immunotherapy naive, second line setting. We did sacituzumab plus pembrolizumab combination, and the trial met the primary endpoint, 41% overall response rate confirmed, 20% complete response rate, a median duration of response about a year or so, and median PFS a little bit more than 5 months. So right now we're actually designing actively in the cooperative group NCTN setting the ECOG-ACRIN 8231 phase 3 trial, asking exactly your important question, Karine. We do Saci plus Pembro versus Saci alone after prior immunotherapy. And the points of entry can be different, can be after adjuvant Nivo or in the future potential adjuvant Pembro, we'll talk about Ambassador in a second, or post-Velma maintenance or post-Pembro EV. So it will be an important question to answer in the immunotherapy challenge question. And I know, Vadim, you have published on that too.
Yeah, I agree. It's a very important question. If patients progress on this immunotherapy containing regimen, EV and pembrolizumab, will there still be activity with another checkpoint inhibitor based regimen? I guess, well, what does everyone think?
I mean, I'm not terribly optimistic that if a patient has been treated with a checkpoint inhibitor and had disease progress in spite of the treatment, I'm not that confident that we're going to see responses. We haven't seen in sort of smaller series, treating with one PD-1 inhibitor to another, very rare to see any kind of response there. As you mentioned in RCC, doing a switch of PD-1 inhibitors has not helped. So I'm not that confident. I do think, though, if somebody had adjuvant nivolumab, finished a year, and then relapsed, there may be a role for giving a PD-1 after the completion of therapy. Obviously, we need to do these studies and find out. But I'm not sure that we're going to see really dramatic responses to checkpoint inhibitors in spite of progression.